I would like to welcome everybody to this fireside chat. And today we have Professor Joe Bonventre. And my name, as I introduced myself, is Dr. Gina Francis Makwabe. I'm a physician and nephrologist here in Tanzania, working with Africa Healthcare Network as a Chief Medical Director. And on behalf of AHN and Professor Lloyd Vincent, our Chief Medical Officer, I would like to welcome you all. And today I'll be moderating this session together with Dr. Jonathan Wala from Kenya. Dr. Wala is a consultant physician and nephrologist he's a consultant nephrologist and physician from Kenya. So, and he works with Aga Khan Teaching Hospital in Nairobi. So today we have, today's topic is acute kidney injury and the role in chronic kidney disease. This will be covered by Professor Joe Bonventre. And therefore, before I proceed, I would like to welcome Dr. Wala to go through his short bio, and then he will introduce Professor Joe. You are welcome, Dr. Wala. Are you there, Dr. Wala?
Yes, Dr. Makobe, you can hear me?
Yes, please proceed.
Okay, thank you very much for that kind introduction. Thank you, Professor, for the privilege of introducing you. Professor Joseph Bonventre, PhD. He's a professor of medicine at Harvard Medical School, chief of renal unit, and the chief of engineering in the medicine division, both at Brigham and Women's Hospital. He is also a director of health sciences and technologies at Massachusetts General Hospital, and is a professor at Harvard MIT General Health Sciences and Technology at Brigham and Women's Hospital. Obviously, his resume is very long, and therefore I'll not go through all the details. Others will miss out on the main parts of the discussion of the presentation and later on the discussion. But he has got a special interest in kidney injury molecule 1. It's all as a biomarker for both renal cell carcinoma and renal epithelial injury, as well as he has had a long-standing affair with investigations on cellular injury and repair mechanisms in the kidney, and with many published articles on this issue. And therefore, it's our pleasure to have you as our speaker today on acute kidney injury and its role in chronic kidney disease. Welcome, Professor Bonventre.
Thank you very much. It's a great pleasure to be able to do this. It would be even more of a pleasure if we could be in the same room, but obviously this is a great opportunity to bring people together from multiple geographic areas in Africa. And I'm going to talk about, as indicated, acute kidney injury and its role in chronic kidney disease. And I try to keep track of, actually, I'm not sure I can get the questions here, but I will, but please interrupt me if you'd like, if something's not clear. This is by way of disclosure. So I consult for a number of companies, primarily in two areas. One in patient safety. Most of the companies I consult for relate to issues of drugs and concern about patient safety. I am involved in some companies that are trying to develop new therapeutics for kidney disease. And we discovered kidney injury molecule 1 and have some patents on that molecule and kidney organoid development patents. So what I'm going to do is divide up the talk into 4 parts. First, I'm going to talk about definitions and diagnoses. And then the pathophysiology, a little bit about treatment, and then end up with the role of AKI in chronic kidney disease, in particular, what we've termed maladaptive repair, leading ultimately to CKD and, in some cases, end-stage kidney disease. So as you may or may not know, this is the International Society of Nephrology Initiative that was introduced a number of years ago, whereby the the goal was to have 0 cases of preventable AKI by 2025, a very ambitious goal, one that is likely not to be met, but on the other hand, representing the recognition of how important this is, and the important statement of the mission of the International Society of Nephrology to do something about acute kidney injury. So I'm going to start with this case. And this is a 74-year-old Caucasian male on the surgical service whose status post a cholecystectomy, who has an increase in his creatinine from a baseline of 1.5 to 2.1 milligrams per deciliter. He has a history of hypertension, coronary artery disease, and pancreatitis. He's been on lisinopril, hydrochlorothiazide, and naproxen, a non-steroidal agent, and has a physical exam where his blood pressure, his temperature was 101 and 2+ lower extremity edema. It turned out his blood pressure was about 130/80 at this point. His urine output was 450 cc's for the last 12 hours. On urine analysis, he had 2+ protein, some blood that was, but very little, so it was actually negative for blood, and a pH of 5. And his sediment showed a few non-pigmented granular casts. Okay, so the questions that I'm not going to answer now, but that I'm going to approach in the context of this talk are, does the patient have AKI? That's the first question. Does he likely have a baseline renal disease? What are the pathophysiological processes responsible for the increase in his creatinine to 2.1? Now, can biomarkers besides BUN and creatinine be helpful? I'm not going to talk too much about biomarkers, but that's always a question. How useful is creatinine? Does he have a higher mortality risk than he did prior to surgery? And will the changes in his creatinine have long-term consequences, and why? And can the kidney repair itself? Can it regenerate? So again, in this relatively simple case, it brings up all these questions that are questions that go obviously beyond this case, but nevertheless, the case tends to focus these questions, and hopefully you'll come away from at the end of the hour in having some answers, if you don't already, to these questions. So, okay, the term that we used to use for that we now call acute kidney injury was acute renal failure. So for many years, we were doing research on acute renal failure, but essentially acute kidney injury, as we now know it, and as we use that terminology, has replaced the term acute renal failure. And part of the history of this really was a study that we actually did at the Brigham in 2005, led by Glenn Chertow, who's now head of nephrology at Stanford. And we just looked at all the patients over the year who had 2 creatinines during their hospitalizations. So that was all that we asked of the database. And we then looked at differences between those various creatinines. And so if there was a change of 0.3 milligrams per deciliter anytime during the hospitalization, we then listed that as greater than 0.3. If it was greater than 0.5, et cetera, we would then codify the increased incidence of mortality, or odds ratio for mortality. And you can see that if you looked at all these patients greater than 30% during their hospitalization had an increase in creatinine greater than 0.3. And that population who had the increase in creatinine greater than 0.3, it could be 0.5, it could be 0.7, but it was greater than 0.3, had an odds ratio for death that was about 11-fold. So they had an 11-fold increase in risk of dying relative to patients who had no change in creatinine at 0.3 or greater. And this study, plus another study that came out about a year or two later at the Cleveland Clinic in postoperative patients, making the same point about the increased mortality associated with relatively small changes in creatinine, led to a variety of consensus conferences and ultimately definitions of AKI. And there was first an acute kidney injury definition, or the AKIN definition. There was a rifle definition, or series of segregation of the different levels of injury. But right now, we have this KDIGO, which is a worldwide definition of acute kidney injury. And it's defined by a change in serum creatinine, a rise in serum creatinine of greater than 26 micromoles per liter or 0.3 milligrams per deciliter within 48 hours. Or the serum creatinine rising 1.5-fold from a reference level, which is known or presumed to have occurred within 7 days. Or urine output less than 0.5 mLs per kilogram per hour for greater than 6 consecutive hours. So this is the definition. And obviously, in many patients, we don't have urine output because they're not in an intensive care unit setting, or they may be in an intensive care unit setting, but their urine output is not monitored that carefully. And so oftentimes, most of the time, we make this definition based on changes in creatinine. Here's the incidence of AKI. This was from Ravi Mehta's paper in Lancet in 2015. The incidence of AKI in studies of hospitalized patients using the KDIGO definition. And so here you can see in North America, it's actually pretty high, 22.3%. In South America, it's 31%. In East Africa, it's 13.4%. Middle Africa, 23.5%. In West Africa, 1.7%. And you know, we're not sure. North Africa, 0.7. Why should it be so much different than North America? Maybe there's more patients that are hospitalized that are not quite as sick in Africa. But you know, I know very little about that. But I suspect this is sort of underreporting and doesn't. And if one had equivalent levels of illness and equivalent information, it may be, for example, in some places in the world, there's only one creatinine determined on a hospitalization. So the diagnosis is missed. But whatever, it's a relatively high percentage of patients that have been admitted to the hospital who develop AKI. And if you look at, and most of these numbers are from countries in either North America or Europe, but if you look at the ICU population, the critically ill population, then you can see the incidence is even higher, obviously, than all hospitalized patients. And in some reports, is as high as 75%. And there are a number of risk factors for AKI. I'm not going to go through all of these, but you know, hypertension, older age, cardiovascular disease, pulmonary disease, Shock, obviously, sepsis, nephrotoxicants, or drugs that are toxic, or environmental factors that are toxic to the kidney, non-steroidals, drugs that affect the renin-angiotensin system, and other factors. Now, another aspect of the definition is that it is staged. And here, so the AKI is divided up into 3 groups, where stage 1 is greater than 0.3, and urine output less than 0.5 mLs per kilogram per hour for greater than 6 hours. Stage 2 is a doubling or close to a tripling of the reference serum creatinine, and higher levels of problems with urine output. So here's greater than 12 hours. And stage 3 is a 3-fold or greater than 3-fold increase in serum creatinine. So if the reference level is 1 in US units, 1 milligram per deciliter, if the creatinine is 3, then that would be stage 3 AKI. Or if the urine output is lower, or if there's no urine output for greater than 12 hours. So here's the incidence of AKI at Brigham and Women's Hospital. This was from looking at 2010. It was published in 2013. But essentially, these are associated diagnoses. Again, we don't have to go through all of them, but clearly, and you take the population with sepsis, close to 70% of the patients had AKI according to the definition of KDIGO. And with more common diseases like pneumonia, almost half the patients who were admitted to the hospital had diagnosis of AKI. And then interventional type of activity or surgical activity, here cardiac surgery 50%, vascular surgery 50%, abdominal surgery 27%. Clearly very common. And here you can see in dark the stage 3, in hash stage 2, and in light gray stage 1. So most patients have stage 1, with fewer patients having stage 2, and in general fewer patients having stage 3. But still, there's a reasonable number of stage 3 patients in this overall population. And again, this is a general hospital. Brigham and Women's Hospital has many patients coming in with either referred in from different cities or referred in from different areas of Massachusetts, or patients who come in, walk in the emergency room. And the mortality, which is not surprising, the mortality is greater depending on the stage. So stage 3 has a greater mortality. Not surprising, because the creatinine is greater, the urine output is less, and so the degree of renal problem is greater in stage 3. But it's not just the stage, and this was a nice paper that came out of Yale at the time when Steve Coca was in Yale. So here's stage 1, stage 2, and stage 3. So if the episode of acute kidney injury is short, basically shorter than 2 days, so creatinine goes up, but then it comes down pretty rapidly, then in fact the mortality rate is not any different depending, it doesn't really depend on the stage. But if it's longer duration, 7 days, then it does clearly depend on the stage. So the worst, when you think about it, there are 2 factors coming into play. One is the increase in creatinine or the urine output drop, but the second, and very important, is how long is that urine output drop, or how long is that increased creatinine maintained. And the other thing to remember is that when someone has a kidney insult or some kind of kidney injury, if they start out with normal kidney function, as reflected by this cartoon representation here, if they start out with normal renal function, let's say this is GFR on the ordinate here, even if they have a reduction in, or they have injury, their creatinine may not drop. And the reason is because there's this term called renal functional reserve. So when, in normal individuals, we have a GFR, but we also have a reserve, and we can increase that GFR. So if some of our nephrons stop working, then other nephrons can take up for that slack. And so this is a diagrammatic representation of that. So it may be the renal functional reserve that drops, but the normal baseline GFR is not changed. Now with recurrent injury, what happens is that the functional reserve in red here keeps dropping. And then in kidney injury, what happens is that there's a drop in GFR. So it's an important thing to remember. So, you know, it's been put in a sort of maybe more direct way. If the patient is 18 years old and they have a degree of injury that, let's say, affects 20% of their nephrons, it may even turn them off. You may not see anything in terms of a change in creatinine. On the other hand, if the individual is 65 years old and they have 20% of their nephrons affected by injury, you're much more likely to see a change in their creatinine. And this is one of the problems with creatinine as a marker. It's not very sensitive, in particular in individuals who are young and have otherwise normal renal function. It's not very sensitive as a marker for injury. And here are some numbers reflecting this renal reserve. So if you take a 25-year-old, this was a small study published 9 years ago. If you look at a population of patients who have an age, the mean age of 25, and you take their baseline GFR of 122, if you give them an acute protein load, you can measure an increase in their GFR to 226. So there's almost a doubling of GFR. Whereas if you take a population in their 70s who have a baseline creatinine with a eGFR of 50, or let's say even one at 81 here, and then you give them a protein load, their functional reserve is there. They can still increase their GFR, but they can't increase it very much. So this population of patients is much more likely, not under these conditions, because here the creatinine wouldn't change at all, because in fact their GFR went up. But if they had injury, you're much more likely to be seeing it as an increase in creatinine and a decrease in effective GFR if they're older. And so here's again a cartoon. If you have, if you could measure real-time GFR, so let's say, and we're developing tools to be able to do this, but they're not quite available right now. They will be soon. But if you can measure real-time GFR, here you can look at this and say, okay, this is a patient who has 50 or 60 mLs per minute. And then you have a kidney insult. Well, their GFR will drop precipitously. But if you're looking at the creatinine values here in micromoles per liter, here you can see that it's going to take a while. This is in days. It's going to take 2 or 3 days before you see the effects of this dramatic drop in GFR, because you need to accumulate creatinine. So this is just important to recognize because the other aspect of this with acute kidney injury is that you may be treating the patient here, or let's say here, 1 day after this acute insult, or 2 days after this acute insult. And you can see that the creatinine is up a little bit, and you're treating them with certain medications. If you treated them with a medication that was prescribed to be treated for a baseline creatinine of 150, you would be over-treating them. Because in fact, their effective GFR is way down here. It's not here, which is what is being reflected by this creatinine, because the creatinine value is not in the steady state. Okay. All right, now let me talk about some aspects of the approaching the patient who has acute kidney injury. And I still think this scheme is a useful one. There's some controversy about this, but I find it still very useful. So in a patient who has acute kidney injury by creatinine or volume criteria, thinking about the patient in the context of whether or not they have prerenal azotemia, we used to call it azotemia, but prerenal acute kidney injury, intrinsic renal, or post-renal with obstruction. Some people think that this term is inappropriate, prerenal, because they say, well, it implies that the person is volume depleted. And it really doesn't. You shouldn't equate prerenal with volume depletion. It means that there is problems getting blood to the kidney, essentially, to the glomeruli. That can be because of volume depletion, or it can be because of vascular problems with limitation of blood flow. Or it could be even intrarenal vascular problems and before the glomerulus, vasoconstriction, scleroderma crisis, severe malignant hypertension. These are sort of a combination of prerenal and intrinsic renal diseases. And then if you decide that the patient's got something going on in their kidney, intrinsic renal problem, then it can be related to the tubule compartment or the interstitial and vascular compartment. Frequently, these are combined. Or glomerulonephritis, acute glomerulonephritis can produce acute kidney injury. And one way to look at this, or to make this diagnosis, or at least do the separation into categories, is to look at the urine. So if there's a red blood cell cast, then it's more likely glomerular disease. If there's dysmorphic red blood cells, again, much more likely to be upper tract disease in the kidney somewhere, rather than, for example, bladder. Here's acute interstitial nephritis with white blood cell cast, although you can't really see the nuclei here. There are ways, hopefully, you know, to really sort of bring out some of the nuclei. There's a trick with acetic acid added to the urine, a couple of drops of acetic acid added to the sediment, and you can see very nicely the multilobar nature of white blood cells. And then there's the granular cast typical for acute tubular necrosis. And then there's these hyaline casts, which, and nothing else, which are typical for prerenal causes of AKI. And in terms of pathophysiology, so when one has some tubular injury, whether it's related to ischemia, or whether it's related to sepsis, or whether it's related to nephrotoxicants, the There's tubular injury, there's endothelial cell activation and tubular obstruction. There's leukocyte recruitment and vascular injury. And the tissue can repair if the injury is self-limited and the background kidney tissue is normal, then the injured kidney can repair and can come back to normal, close to normal, by proliferation of the epithelium, by resolution of the inflammatory infiltrate, by going from inflammatory to reparative categories of macrophages. But in many cases, especially if the kidney does not start out as normal, or if the injury is severe, or if the injury is repetitive, then there's impaired repair and fibrosis. Okay, so in thinking about, these are some questions that one of our junior faculty members, Ankit Patel, put together recently. And you know, if you're a nephrologist and you're asked to consult on a patient, you know, what are some of the questions you ask? Or if you're a hospitalist and you're thinking about the patient, again, these are some questions. You know, what's the baseline kidney function? When's the onset of acute kidney injury? What are the potential etiologies of acute kidney injury? Reviewing medications, reviewing blood pressure, what's been the urine output, and what are some of the laboratories studies? You know, some may not be available completely to you, but the urine analysis, I think, would be the serum, blood urea nitrogen, creatinine values, a urine ultrasound, a renal ultrasound to make sure to rule out some obstructive component, because that obviously changes the whole direction of treatment and therapy. And if there's any suggestion at all that it could be an autoimmune phenomena, glomerulonephritis, getting complements or other laboratory tests that are available to you to test the autoimmune system possibilities. And so there are many causes, many causes. I like to lump them together rather than try to figure out a cause for each individual one, because I really believe that in many cases, including medications, not in all cases of medications, but in many, reduced effective intravascular volume, renal vascular disease, and small vessel diseases, they all converge on this generalized or localized reduction in renal blood flow with ischemia and acute kidney injury. And sepsis also comes in here. So again, I think this is a useful way to think about the pathobiology, because in fact, things converge. Clearly, in some of the, if you look at cyclosporin, that clearly comes here because it's vasoconstrictive. Angiotensin converting enzyme inhibitors and nonsteroidal agents affect intrarenal blood flow distribution. Contrast agents are important for vasoconstriction. Okay, another important aspect of thinking about the patient who has acute kidney injury is to know something about the vasculature and the tubular relationships in the kidney. And so here's a cartoon. It's not to scale in any way, but it focuses in on the outer medulla of the kidney, where much of the ischemia occurs with acute kidney injury. And so here's the glomerulus in the cortex. Here's the proximal to convoluted tubule, the proximal straight tubule, and then the thin descending limb, ascending limb, and thick ascending limb. And in the outer medulla, there's this vascular network. And what happens with AKI or sepsis is in many causes of AKI, is that this vascular network gets compromised. And this causes ischemia to the proximal tubule, the S3 segment. And why is that important? Well, for two reasons. One, the S3 segment is very dependent on oxygen, and it's therefore very dependent on blood flow. But the second thing is that because of the way the medulla of the kidney is structured, there's a gradient of oxygen tension from the cortex to the tip of the inner medulla. So basically the inner medulla, there's no oxygen. And the cells are very much adapted to this. They're glycolytic in their metabolism. In the outer medulla, there's hypoxia. And this hypoxia gets worse as you go down, deeper into the outer medulla. Down here with a thin descending limb, these structures are not very oxygen dependent, although they do have mitochondria. But clearly if you reduce this blood flow a little bit, you're going to really cause havoc in the metabolism and ultimately then kill the cells in the S3 segment. Now, another way that you can obstruct flow here is, one way is by decreased renal blood flow, but the second way is by causing inflammation in this area, which is part of acute kidney injury, and extravasation of fluids into this region. And this is very important, and I'll come back to this, when you're treating patients who have generalized edema and sepsis, let's say. The thick ascending limb doesn't die as a result of removal of oxygen because it can convert to glycolytic metabolism. So here's a situation. This is more to scale. These are the vasculature in the outer medulla. This is the boundary between the outer and the inner medulla, very, very sharp vascular boundary. And this is a postmortem specimen of a human kidney of an individual who died with acute kidney injury. And you can see the obstruction in the vessels here of the outer medulla. This is the outer medulla. Another thing that happens in the vasculature is that you lose the integrity of the glycocalyx, which is protecting the endothelial cells. And once you do that here in post-AKI rather, you then have an unprotected endothelium, which then attracts platelets and causes obstruction of small vessels. So this causes a secondary ischemia as a result of the small vessels. In this case, it's in the glomerulus because these are podocytes, but it happens also in the tubule or the vasculature, the peritubular vasculature, here reflected by the tubule. It happens in the tubule also that these membrane protective agents, this glycocalyx gets removed from the cell membrane and hence exposes the cell membranes to inflammatory influences. Here was a study that we did in mice, and this was using ultrasound as a way of looking at blood flow. So it doesn't have that high a resolution, but it's non-invasive. And you can see that red means a good deal of blood flow. So even after a period of ischemia of about 25 minutes, if we looked at 24 hours after it, we still didn't have complete blood flow to the entire kidney. And by 60 minutes, there was not a restoration of blood flow, even though we had removed the clamp after in 26 minutes, after 26 minutes of ischemia. It takes a while for the blood flow to actually reopen up all the small vessels and restore blood flow to the tubule. And this is an interesting older study demonstrating this. This is ischemia. This is a rat kidney, ischemia, and then reperfusion, so that the blood flow in the cortex after reperfusing the kidney, after clamping the renal artery and unclamping it, the blood flow was 60% of normal, and in the outer medulla it was only 16% of normal. And in the inner medulla it was 125% of normal, which is sometimes confusing to people. How could it be higher in the inner medulla than it is in the outer medulla? So I'll go back to here and just remember the vasculature. Blood flow comes in and it goes through the vasorecta bundles into the inner medulla, and vessels come off to perfuse the outer medulla. So if you prevent the vessels from coming off because you've obstructed them, then all the blood flow will go to the inner medulla. So the blood flow to the inner medulla will be normal, but the outer medulla will be severely impaired. Okay, so I'm going to be mindful of the time, and I'm going to skip over a couple of slides, but I just want to make a few more points. This is the tubular involvement in acute kidney injury, and you can see the interstitial inflammation. You can see the loss of the glycocalyx, which normally protects the endothelium, the extravasation of inflammatory cells, and the tubular injury and tubular damage. This is what a nephron really looks like. So don't use the images that are in textbooks because most of them are wrong, and in two contexts. One is that this is the reason, so this is done by directly injecting the Bowman's capsule around the glomerulus and clearing the tissue so that you can see some of the blood vessels, but the blood vessels are only partially filled with what essentially is a red silicone rubber that in black and white looks gray. And the tubule is filled with white silicone rubber. And so you can see that it's very convoluted, but the other important thing that you see here is that the glomeruli are actually providing blood vessels. Sometimes you can see it better than others, but providing blood vessels to the tubule. So this tubule is provided, its blood supply is provided by approximately 10 glomeruli in the cortex. This is not generally appreciated, but what it clearly means is that if you knock out this glomerulus, one glomerulus of these 10, you can basically damage this part of the nephron, and if you can then obstruct it and potentially inactivate this entire nephron, even though the glomerulus of that nephron was fine and the efferent arteriole is fine. So there's a complex interplay, which is particularly important when you look at sections of the kidney and you think about the crosstalk between nephrons. Okay, I have a little bit of COVID here, just all of you are well aware of this pandemic. These are sort of a compilation of studies showing that AKI is very important in many of these studies relating to, in particular, in ICU patients. As many of you probably know, it's a major component of the pathobiology. And there are many reasons for it here. So, there's vascular consequences of COVID affecting coagulopathy. There's a cytokine storm, which can affect the blood supply in the kidney, can affect the glomerulus, can affect the virus itself, may directly act on the tubules or podocytes. This is controversial, but I can tell you that we just sent in a paper whereby in a small subset of patients on postmortem, we actually can find the virus in the kidney. There's, again, some controversy about this, but it doesn't happen to all of them, and there may be there's a lot to be learned about this, but there is virus in the kidney. And then I would say that there are many other things that are going on in the ICU that can contribute to acute kidney injury. So all those other factors that are present in the absence of COVID, hemodynamic instability, nephrotoxic drugs, high level use of PEEP, positive end expiratory pressure from ventilators, and cardiac and lung dysfunction. These are all factors that are contributing to the AKI in the COVID patient. And there's also effects of AKI on distant organs. So AKI can also affect the heart. And it's seen in the setting of COVID, but it's also seen in many, if not all cases of significantly ill patients with AKI. They will have consequences to the heart, and not depicted here. They'll also have consequences on the lung and potentially even the brain. And this relates to systemic effects that are going to act on other organs in addition to locally. So oxidative stress, endothelial dysfunction, for example, is found in the heart, it's found in the lung, and it's also found in the brain of individuals with acute kidney injury. Okay, in terms of treatment, there are many treatments that have been in development, but I want to just present a volume treatment because this is something that you're all doing, and only very few people have access to novel therapies for acute renal failure or acute kidney injury right now. So here's fluid management question, a basic fluid management question. So which of the following is false? So buffered solutions, these are Ringer's lactate, Plasma-Lyte Hartmann solution. I don't know which ones are available to you, but these are solutions that have more than normal saline in them. These are recommended for patients at risk of AKI who are not hypochloremic. So this is correct. So this is a correct statement. Albumin decreases fluid requirements for resuscitation, improves survival, and reduces the need for renal replacement therapy compared to crystalloid. So this is not correct. So albumin does decrease fluid requirements for resuscitation, but it does not improve survival, and it does not reduce the need for renal replacement therapy. Okay. Starch should be avoided, that's true. And normal saline can cause vasoconstriction, that's true. So that's the reason why, in general, this first recommendation is made in terms of treatment of patients who need volume replacement with AKI. Again, not all patients do. Some of them need to have volume removed. But this first recommendation, and certainly this recommendation 3, are the 2 recommendations that are made. You can use albumin if you have it available to you, but it's expensive, and it really doesn't change overall survival or reduce the need for dialysis. And again, I'll come back to this notion that, when we think about volume in patients who have AKI, we often are presented with a patient who is grossly edematous. And when you see that patient with marked edema, maybe they've received a lot of fluids already, that's usually the case, think about their kidney and think, well, why isn't this the case in their kidney? Sure, it's the case in their kidney. And the kidney is bound by this very dense fascia that's non-expandable. Whereas the skin can expand, their kidney can't. And so, you know, the correct approach, even if the blood pressure is a little bit low, is not to give more fluid. It's actually to try to reduce the fluid, remove the fluid, and maybe give pressor agents, vasopressive agents. This has become more and more appreciated by the intensive care unit providers and nephrologists and critical care investigators and clinicians throughout the world. Again, I just showed this slide. These are slides of therapies that are in development. Some of them are anti-inflammatory. Some of them are antioxidants, improve mitochondrial function, facilitate regeneration, prevent cell death. So we won't go through these. They're in varying states of development. What about dialysis? The question comes up in AKI, whether you should dialyze the patient earlier versus waiting. And fundamentally, the bottom line here is, and I'll show two studies which show no difference. So the notion is that if you dialyze patients early, before they need it, and they do not do better than if you wait and see if they need it and then dialyze them. And this was one study. So this is patients in terms of survival, using the early strategy within 12 hours of the diagnosis of stage 3 AKI, or the delayed strategy, greater than 24 hours after the diagnosis, or greater than 12 hours of anuria. And here's another study. This one just came out in 2020 in the New England Journal. The same thing, accelerated group. This was continuous renal replacement therapy, or waiting. These were the mean creatinine levels at the time of initiation, and so they were higher, obviously, if you waited longer, but there was absolutely no difference in patient survival. And there was no difference in any real subgroup. Okay, and let me just take a minute or two then. So AKI leads to CKD, and CKD predisposes to AKI. So in the natural history of AKI, when there's a sort of maybe pre-renal stage, there may be an initiation stage, then there's a maintenance stage and a repair stage. But the repair stage could be back to normal levels, let's say, of GFR. But in most cases, certainly with patients who start out with underlying kidney disease, it's only partial. And here it may not be at all, and the patient may need to be on renal replacement therapy. And I remind you then of this feature of renal reserve. Over time, your renal reserve decreases, so you have less capacity to make up for injury. Here was an older study in 2009, just showing that patients admitted to the hospital, all patients, if they had a diagnosis of AKI versus if they did not, the odds ratio, probability of their developing end-stage renal disease over the next 2 years was markedly increased. And here it's divided up a little bit more. These are the patients who had AKI on top of CKD, and these are the patients who had AKI, and these here are the patients who had CKD alone. And you can see that the probability of developing end-stage renal disease was equivalent in the AKI population without CKD as it was in the CKD population without AKI. So AKI itself predisposes to end-stage renal disease. And if you look, on the other hand, and you say, well, what about CKD? Does that predispose to AKI? Here is a group of individuals in the ERIC study with the atherosclerosis, the risk in community study. And this study has a high representation of individuals of African-American descent in the US. But in any case, it has, if you look at patients, men or women, and here's increasing urinary albumin to creatinine ratio as a marker for chronic kidney disease. So as you move to the right, there's more chronic kidney disease. Here you can see AKI incidence goes up. Men, women, whites, blacks, age less than 65, age greater than 65, EGFR less than 60, EGFR greater than 60. So again, the albuminuria as a marker for kidney disease predisposes to, or is associated with a predisposition to AKI. And in repair, I would just show this at a mechanistic level. There's injury, there's a variety of different cellular mechanisms, including cellular senescence, which results in a maladaptive repair that leads to progressive scarring in the kidney. And so if you take one case, or not a clinical case, but the situation of diabetic kidney disease. So someone with baseline diabetic kidney disease, no matter almost at what stage they are, they will be predisposed to the development of AKI, and AKI will facilitate the progression of their diabetic kidney disease. Okay, with that, that's my last slide, and you know, I've tried to then go over a variety of aspects of acute kidney injury, bringing in the mechanistic with the clinical applications, because I think it's very useful to think about mechanisms when you're thinking about a patient who's lying in front of you, who has a reduction in renal function, who has an abnormality in fluid status, and who you're trying to treat and restore them to a condition where they'll be able to survive. So thank you.
All right, thank you, Professor Bonventre, for the very wonderful presentation. That was very comprehensive. We really appreciate it. So we have some few minutes for questions.
Yep.
And if there's any questions, please, you can ask. He's ready and he's listening.
Question here?
Yes.
Yes.
Okay, yeah, Dr. Ndembe from Rwanda. Now, thank you, Professor Bonventre, for this excellent presentation. Now, it just raises more questions, particularly about creatinine as a marker of acute kidney injury. In the last maybe 2 or 3 decades, nephrologists and physicians have been complaining about the flows of creatinine. Then, as I think in the year in 2000, just before 2010, there were these other biomarkers of acute kidney injury. I think the first one was probably cystatin C, or maybe some others earlier. Cystatin C, then came kidney injury molecule, then there came NGAL, there a lot of others. Now, is there a possibility in the future that this anxiety caused by creatinine coming late is so that we can pick on one particular molecule that will give us, ring the bells earlier that there is a problem with, there's acute injury going on, instead of waiting late to take action?
So I apologize because I caught pieces of that. The sound transmission was not great, but can I rephrase your question and just ask if it's the correct one? So your comments relate to the use of creatinine and the criticism that I laid on its use, and what is the status of AKI biomarkers like NGAL or like KIM1 at the current point in time, and why aren't we using them? Is that sort of does that capture what you'd like me to respond to?
Yeah, the idea is, I mean, in the last 2 or 3 decades, there has been this knowledge that creatinine is not actually a good marker.
Yes.
Then now, what does the future hold now for creatinine, especially now these that are coming? Is there any possibility in the near future that we should resort to those more accurate ones?
Okay, so yes. So number one, the issue with agents like creatinine is, or that accumulate in the blood. So people are looking for other GFR markers, but if they accumulate in the blood, they're not going to solve the problem of the delay in time. For example, if you look at cystatin C as a marker for GFR, it's not going to increase any quicker in a non-steady state. So I think we need to just recognize that. So what we need are markers that appear in the urine early on. And what I would tell you, obviously I'm very biased toward KIM1, kidney injury molecule 1, but NGAL is, very good also. And clusterin is another very good one. It's been shown in a number of situations. Right now, there's been a lot of frustration about the acceptance of these, primarily because of the fact that the studies are done using creatinine as a gold standard, which doesn't make any sense, right? In other words, if you're trying to replace creatinine and you're using it as a gold standard. Well, I have slides, a whole presentation about that, but that doesn't make sense. And so that's been a major problem with the acceptance of these markers. The FDA in the US is very aware of this. And I would say that right now the ASN and with the Kidney Health Initiative, and I'm helping to work with them. I've been working with them on this. There's a major initiative that is starting right now to really deal with biomarkers of acute kidney injury, and this is an initiative that the FDA is very much supportive of. In fact, the FDA in the U.S., the Federal Food and Drug Administration, has been the group that has really promoted the use of, basically has promoted that we do this. And so the other thing I would say is that there is another technology, two companies, one of whom I'm an advisor for. So again, I just want to be clear about that. And this company has a device whereby you give an injection of a fluorescent molecule, and there's a detector that you put on the chest. And within an hour or so, if you monitor for an hour, you can get a real-time GFR. So you get the actual GFR at that time. And so I think the future, and this is not that complicated a process. In fact, it's, I think it's something which can be brought to your environment, not right away perhaps, but I think it's going to be sort of a bedside small box, and with a recorder on it to show the decay, basically the decay of the fluorescent compound in the blood. And since the fluorescent compound in the blood is excreted only by the kidney, it's going to give you a way of detecting GFR right away. And so I think, you know, this technology, there's another company called Fast Bio that is also trying to do it. A little different technique, but it's the same general principle to use markers in the blood. So you do a small injection, and then you measure the function in real time. So I think that's going to be that coupled, because you won't be able to do that necessarily in every patient all the time, obviously, but that coupled with a urinary biomarker, which triggers an initial signal. You know, we thought at one point about calling it renal alert, just to alert the clinician that there's some problem and they should pay attention to the kidney. And then you could do more fancy analyses, but after you got that alert in the intensive care unit or even on the wards, that somebody is using a dipstick or something like that to detect the biomarker.
Chairman, can I ask a question?
Yes.
Thank you very much for that excellent presentation. My name is Dr. Anthony Were from Kenya. I'd like to get your views on management in terms of comparisons in critical care patients between intermittent hemodialysis, slow extended daily dialysis, and CRRT in terms of mortality, in terms of outcome. Yeah. I'd also like to get your view on the best management of COVID in critically ill patients with COVID, yes, with acute kidney injury.
Okay. Okay, so with respect to intermittent and slow and CRT, you know, I would say that there's really, after all these years of trying to show differences in mortality associated with those therapeutic interventions, I would say that there really is no compelling argument for one versus the other. In fact, you know, I think if you looked at the study that was done in France, you know, there was a learning phase because so many trainees are not trained in the use of intermittent hemodialysis in the acutely ill patient, that they, you know, it's probably safer for them to do CRRT. But if you have available to you intermittent and not CRRT, there's no reason really to think that you're doing a disservice with regard to overall survival. Now, from a practical point of view and from a volume maintenance point of view, you know, we do a lot of patients with CRRT. It's available to us, and you know, there's a generational issue here also. Those of us, including myself, who didn't have CRRT when we were in training, we had intermittent hemodialysis. We learned how to dialyze patients in the ICU with intermittent hemodialysis, even if they were hypotensive. You know, in the last 10 or 20 years, since at least in the US, when we've had CRRT, patients or physicians are much more comfortable using it. Now, with regard to SLED or SLOD, again, that's a very viable alternative. It really depends on what your local environment allows you to do. And so with regard to COVID, for example, we started out using CRT in many of our patients, and then we basically didn't have enough CRRT machines, so we then did intermittent hemodialysis, and with some patients we did slow intermittent dialysis. But in fact, from a personnel point of view, we were being really taxed, and so it was much more efficient for us to do regular intermittent hemodialysis and to, if the patient was really hemodynamically unstable, then we would devote the CRRT machines to those patients. So we didn't do too much, slow dialysis. And with regard to therapy, I think from the perspective of the kidney, we don't really understand what's going on right now. We don't have any positive studies that I'm aware of in terms of intervention. There's some things out there with vitamin D, and there's remdesivir, and sort of general treatments. The notion of ACEs and ARBs, that is something we do not recommend taking the patients off if they need them. But then when usually in the hospitalization, when their GFR went down, a number of the patients came off of those. But even there, it's not clear that that's helping. So I don't know if that answers your question. I think there's the steroids. We need to get more data, anecdotal data on. Unfortunately, much of it has been uncontrolled at this point, but on anti-inflammatory approaches, because there's some theoretical reason why anti-inflammatory approaches might be effective by decreasing the cytokine storm.
So what's the main reason for the decreasing mortality in COVID in your country?
Yeah, so it's just improved care in the sense of pulmonary care. I think more rapid, better use of ventilators. At one point, I think one thing that we point to is the we were probably ventilating people too early on, and then we went to more prone condition and that kept a lot of people off of the ventilator, and then we started using agents. We started using some steroids. We started using the remdesivir. We probably got better at fluid management, understood more about the fact that we could give fluids without causing as much pulmonary complications. But we're still trying to sort through that. Maybe a little bit earlier diagnosis, a little bit in the context of, when you compare those numbers, we're diagnosing people more. So the overall rate of serious illness goes down because we're picking up less serious illness. So I think that's, it's a combination of factors. It certainly was very scary in New York and Boston initially. We were running out of, we never quite ran out of ventilators in Boston. They did in New York, from what I understand, and they were rationing therapies in New York, and we were talking a lot about having to ration therapies in Boston. And I know you're in an environment where you're used to, unfortunately, rationing therapies, but we are not. And so, it was very scary for all of us.
Thank you, Dr. Bonventre. Dr. Jonathan Wale here. Reading some of the questions from the chats. What is your comment on stat use in AKI? What is your comment on stat use in AKI? Can you elaborate a little bit more on that? And the more difficult one about elaborating on the maladaptive healing of AKI.
The healing of AKI. Is that the question? Okay, I think the only thing that we can do right now is really
the first question is use of starch in AKI.
The use of fluids in AKI or starch in AKI. I'm sorry, I didn't get it.
Yes, starch
Use of
the egg. Okay.
as a fluid replacement therapy.
Oh, the fluid replacement therapy. Yeah.
Yeah.
So fluid replacement therapy. So in an individual who has a low chloride, basically we will try to increase with normal, we'll treat with normal saline to get the chloride up. There's some feeling that, you know, if you treat with normal saline when the chloride is normal, that actually has a vasoconstrictive effect. So we try to avoid normal saline if the serum chloride is close to the normal range. In which case then we use crystalloid, you know, whatever solutions are available to you, Hartmann's solution or Ringer's lactate. You know, there are issues with lactate if there's liver disease, but essentially we use these buffered solutions if the patient's chloride is normal. We don't use albumin. You know, and I think in particular in resource limited environments, it's hard to justify the use of albumin, except in maybe some rare situations where someone has severe nephrotic syndrome and you're trying to prevent them from developing AKI and you're treating the nephrotic syndrome, you know, giving some albumin. I mean, we do give albumin under certain specific situations, but in general, if it's a critically ill patient with sepsis, you know, we try to treat with crystalloid and with buffered crystalloid. The use of albumin will reduce the need for will reduce the need for crystalloid, some of the need for crystalloid. So it really, it's a little bit, gets a little personal there. Some people still use some albumin, but it's hard to justify in most cases. The other thing I would say is I would really be, in terms of fluid management, be very cautious about the amount of fluid I'm giving to a patient who is edematous, in particular if the edema involves the upper extremities, just because of this fact that you have a confined space in the kidney, and that by giving more fluid, it's going to extravasate into the outer medulla and the renal parenchyma, and you're essentially going to get a page kidney. We used to call it something like a page kidney, but in any case, it doesn't matter what it's called, but you're going to get a kidney whereby there is tense pressure buildup in the kidney. So the individual that you get to, that you're being asked about fluid management for, who has accumulated already 10 liters during the hospitalization and who is edematous, then I would be much more likely to push for a pressor, a vasopressor agent, if I needed to support their blood pressure.
So, Prof, thanks for that answer. From Amani, her question was about maladaptive healing of KI towards CKD. And previously, that question from Frida, she elaborates that she wanted to find out colloid starch use instead of albumin. Why are you against it?
Because there are some clinical studies. There are some clinical studies which show when they've been randomized that the outcomes in those patients with starch, getting starch, were worse.
Okay. And the maladaptive healing of AKI to progress CKD.
What about it? So in other words, what we're trying to do is develop to understand it, and we do understand parts of it, and there are therapies that we're trying to develop to basically prevent it. For example, one of the important components we feel is cell cycle arrest, because of senescence. And there are therapies which are being developed by pharmaceutical companies, whereby they're using something they call senolytics. So agents that are specifically targeted to kill cells that are senescent. And so, by understanding the biology, then we can think about targeted therapy.
Okay, thanks a lot.
A question, Dr. Wala?
Okay.
That's a question. My question is, where would you best put your money in terms of research in Africa on acute kidney injury? Like in the area of maladaptive process, would genomic studies be of any value to check on the genetic makeup of individuals who end up developing chronic kidney disease after acute kidney injury? Where would you best put value for money in research on acute kidney injury?
Well,
in Africa?
I think that number one, the recognition or the early detection is one area that but in terms of maladaptive repair, I think if one could do the genetics of patients who develop AKI, clearly there's likely to be some predisposition, and I would also put my money, as I'm trying to promote people to do in the U.S. In a variety of contexts, is to follow up. It's, in other words, if possible, and I understand this may be more possible in the cities than it is in the more rural areas, but to take patients who are who've had AKI and do the genetics there. Well, you've got the genetics already, and look at the let's say the discharge information on those patients. What their creatinine, what their estimated GFR was, because that's all we have right now. What collect urines for biomarkers, collect bloods for biomarkers, and then look at 90 days afterwards and follow for a year. Then look at a year later and see what their renal function is at that point by looking at biomarkers and an estimated GFR, and be able to then see whether or not you can predict in the context of your measurement when the patients leave. And then where I would put my money is when promising therapies are out there, to treat those patients when they basically are ready to leave the hospital, or and treat them chronically going forward to try to prevent recurrent bouts of AKI, which are likely to be subclinical. And so I think that chronic kidney disease is essentially bouts of subclinical AKI, where different parts of the nephron are being affected by ischemia. It's just that not enough of the nephrons are being affected to bring the patient into the hospital, or for them to know what it is that is going on. So I would put money right now into early detection, to summarize, and to basically the genetics, and trying to understand if there's predisposing factors. And if that's the case, and I know there are partners, there are many drug companies that would, I think, love to partner with you in that, because clearly genetics has a lot to do with kidney disease and its predisposition.
Thank you.
Can I ask a question?
Dr. Tair.
Yes.
And I think that will be the last questions, and then we'll leave. We'll leave Professor to go and do other things. All right. Can you proceed with your question, please?
Okay, thank you, Professor, for your talk. I want to take you back to the role of serum creatinine and GFR in our clinical management of our patient with AKI. When I see my patient with AKI, I'm not looking at the staging 1, 2, 3. I'm looking at whether the patient has a high potassium pulmonary edema. And so what's the utility of looking at the rifle criteria, the KDIGO, and the AKIN? Are they really useful criteria, or actually they're a waste of time?
Yeah, okay, good question. To the extent that there is a predictive nature to those values, I think that's useful in terms of just determining how severe the patient is, because in the context of hyperkalemia, as you know, that can be, depending on a particular baseline renal function, that can be dependent also on other things like hemolysis or other things that might be going on in the patient that won't necessarily be only their renal clearance of potassium. In the context of edema, fluid management, that's not only a renal issue. If you're thinking, all these patients are on a variety of different drugs, and those drugs need to be managed based on what your estimate of their GFR is. And if the person's got stage 3 GFR, or stage 3 AKI rather, then you basically are dealing with an individual who's probably got an estimated GFR of what, 12, 15, and rather than a person who's got stage 1, you're dealing with them. Even if you're not quite at the estimated, right at the steady state yet, but their creatinine is just going up a little bit or very slowly, then you're dealing with a person who has probably an estimated GFR of maybe 40 or 50, depending on how what their baseline creatinine is. So I think in the context of I think it's useful to stage. I don't think that I hear what you're saying in terms of management. We don't have a personalized therapy which says, right now, if somebody's got stage 3, they should be dialyzed, or if someone's got stage 1, they should be dialyzed. We know right now that that's not the case. Obviously, the individual with stage 3 is much more likely to develop hyperkalemia and much more likely to ultimately need dialysis treatment. But the staging per se, that number, the way it's developed right now, is not going to be an indicator of an absolute clinical decision. So.
All right. Thank you, Professor Bonventre, for the wonderful presentations.
Okay. Well, I appreciate the opportunity. I really do, and I appreciate the the involvement and all the questions. And seems like nephrology is alive and well in East Africa.
Sure. Thank you, Prof. We really learned a lot of new development in AKI, and we really appreciate your knowledge and everything that you have provided with us. So that we have come to the end of our today's presentations. I would like to thank my my colleague, Dr. Wala from Kenya, and also would like to thank all of you who participated in this webinar. And next week, speaker and topic will be announced later through your social media. So if there's any comment from Professor Lloyd, I will welcome. If no comment, then thank you very much, Dr. Bonventre. and then see you all next week.
Okay.
Thank you very much, Dr. Bonventre.
Okay. Thank you. Bye-bye.
All right. Bye. Bye-bye.
Thank you very much, Dr. Bonventre. It is an excellent presentation. We learned a lot on the talk, and a lot of the newer development, especially the pathophysiology, was excellent. A lot of learning, and the explanations to that, especially the blood flow there. Thank you so much.
Great. Yeah, and if there are any questions about anything, you know,
we can mail them across. We will mail them across.
Okay.
Gracias.
Bye-bye.